what we're going to see in our next one here, Emerging Strategy in Cataract Surgery, is one of our groups in Ontario who's put a stake in the ground and trying to do something helpful for their patients. And like I said, it's always easy to, find errors in their ways, which I'm sure we will see some shortcomings, but really kudos to Toby, Carissa. We're trying to get you promoted here as well. I'll just do some introductions here. So we have quite a few panelists, some which we've already introduced. Ike, you've heard from Ike. I won't introduce him formally. I was thinking Ike also probably has the distinction of having the highest anterior vitrectomy rate in our country. So you can think through what that means.
Thanks, Matt. Thanks, buddy. Thank you very much for that.
You're welcome. You're welcome. I'm probably not far behind. Toby, I think, is probably fairly good at this as well. So kudos to you and your anterior vitrectomy rates.
Well, Matt, you know that's because you and Toby were two of my former fellows. That does account for something, I think, perhaps.
So we learned from you. Okay. Well, think about that. But anyway, let me formally introduce Toby. So Toby is the co-division head of ophthalmology at St. Mary's General Hospital and Grand River Hospital in Kitchener. And he's also an assistant clinical professor of ophthalmology at McMaster. And I said, do not think because he's in Kitchener that he is not an academic clinician. He very much is on the health services side, on the cataract side, and also on the glaucoma side, where I have the pleasure of interacting with him as well. So he's going to be presenting on the central intake program for cataract surgery that they've been developing. For our panelists, we've already heard about Dr. Reed, Dr. McCreely's, our high volume anterior vitrectomy surgeon. And we have Carissa McAllister, who I also know well, and again, in Kitchener, but incredibly academically minded in her pursuits, still very involved with medical students. She is a true general ophthalmologist. She does it all, in addition to being a very busy mother, writer, very involved in ethics, a true example in many ways, I think, of how we can be a clinician and more. And then I'll introduce Sean after, when we get a little bit more into our wait times talk. So go ahead, Toby.
Thanks very much, Matt. Thanks, Ike. And yeah, congratulations to the event organizers for this wonderful virtual conference. I think it's a great initiative. And yeah, it's truly an honor to be here. And I feel bad mentioning the V word in front of all my esteemed retina surgeon colleagues. So let me, without further ado, just share my screen here. Everyone can see it all right? Let's see here.
We can see it, not yet on present. There we go. Yep.
Great. So yeah, first of all, I would like to give thanks to Dr. Carissa McAllister, who's my co-division lead of ophthalmology in Kitchener. None of this would have come to fruition without her initiating idea. And it's been a pleasure working with her here in Kitchener and just bringing this to the table. So these are my financial disclosures, none of which would be pertinent to what I'm going to talk about. To give everyone a little bit of a background, so we are located in the Waterloo region, which is consisting of Kitchener, Waterloo, Cambridge, and Guelph, 4 kind of townships. We're about 40 minutes of driving distance from where Ike and Matt are in Mississauga, Toronto area. We cover a population of close to 750,000 people. And in this region, we have 14 cataract surgeons right now, but you can see the wait list range can be quite variable. And I'm sure that's the case in most communities as well. And for us, it varies anywhere between a few months to 2 years or more. And the pandemic just made everything worse. It just dragged on to beyond 2 years. And locally, we started thinking about solutions to how can, the status quo is not going to be acceptable. How can we do things differently? And what better than, steal ideas from other subspecialists or specialties? So what we thought of was this central intake or centralized e-referral system that would triage all cataract referrals for our region. And apparently looking at the data, we can see that there's already been a lot done on the orthopedic side in British Columbia and Nova Scotia and Manitoba, and also in Ontario. And on the right side, you can see there's about 10% reduction in terms of the number of patients waiting for more than 6 months for hip and knee joint replacements in British Columbia, close to 90% reduction in patients waiting for more than 3 months for surgery in Saskatchewan. Ontario Medical Association is actually advocating for centralized e-referral system. So if we look into other reasons other than wait lists, reducing wait time and wait time variability, it also allows us to improve access and flow of patients through the health system. It streamlines and kind of equalize the referral practices across different surgeons, eliminating bias towards surgeon referrals based on existing referral patterns. So for instance, some optometry centers may have preferences to refer specifically to only specific surgeons. So that may allow or lead to a little bit of a polarizing distribution in terms of wait time within a region. So there's this survey that was done by Ontario Health going to Toronto and central regions that actually found out 75% of surgeons in that area are willing to redirect their patients to a surgeon at a different site if they had a much shorter wait list for surgery. So a lot of referring healthcare providers, they don't really know who has the shorter wait list in the region and who has the longest, and same goes for patients. So if we want to carry this out for cataracts, this is kind of the roadmap that it would look like, starting with the patient having the diagnosis of a cataract that requires surgery, the referral source, which is very often the optometrist, and at times it would be the family physician that gets the information from an optometrist, sending a referral traditionally directly to the surgeon's office. But if we have a central intake system, that would be the system where all cataract surgery referrals would go to. And once the central intake system takes on the referral, they will notify the referring source, distribute into the database looking at perhaps who has the shortest wait time, unless the referring provider specify which surgeon to want to send this to. And then once the central intake system localizes which surgeon has the shortest wait, the referral will be sent to that surgeon. That surgeon's office will book the appointment and then notifying the patient and the central intake system, which would then notify the referring care provider. So this is kind of a schematic. Now we have an idea of how it should be done. Now, who should we talk to make this work? Because we are no programmers or software engineers. So locally, right at our doorstep in Kitchener-Waterloo is the eHealth Center of Excellence. And in the picture down below is Dr. Mohammed Al-Arakia. He's a family physician with very, very strong passion in using technology to improve healthcare for our patients. So this was actually an organization that was established in 2014, and it's been in very strong and close partnership with Ontario Health, with our ministry provincially, to roll out different platforms to use technology and improving healthcare experience for our patients. So, and apparently they already have this existing central intake system working for diabetic screening and also for hip and knee replacements locally here in the Waterloo region. So we're basically utilizing existing infrastructure, but applying it to cataract surgery here. And knowing that, the Kitchener-Waterloo region is kind of the Silicon Valley of the North in Canada, we just thought, where else better to use technology to improve the waitlist that we have. So we applied for provincial funding in April 2021. We got this one-time funding to launch the program, and it allowed us to be the first centralized e-referral or central intake system for cataract surgery in the province. Again, it's facilitated by the Waterloo Regional Coordination Center that already had experiences with central intake, with the goals of allowing us to shorten wait time for cataract surgery, equalizing the polarity in the distribution of wait times across different surgeons, and allow better access for our patients so that patients can access the waitlist data, the referring care providers can look at the waitlist numbers, and it just allows us to utilize this existing e-referral system called Ocean to carry out what we want to do here. So this is a layout of the website that we have with our Waterloo Regional Eye program. You can see on the upper right-hand side, there's a tab to click for referring patients, and this is what the introduction is. So it utilizes this program called Ocean, and on our website, we publish our waitlist data that gets updated regularly and monthly. And to those who are not familiar with the Wait 1, Wait 2 system, here in Ontario, Wait 1 indicates how long it takes from the time the referral is made to the patient is seen in the ophthalmologist's office. And Wait 2 is how long it takes from that appointment initially with the ophthalmologist to the day of the surgery. So you can see across all our surgeons locally in 3 hospitals here, there's quite a wide range in terms of distribution for weight 1 and weight 2. And we also have a column indicating the total weight in number of days. So this is totally transparent and open to everyone online. And if you go onto our website, you'll see it being updated regularly. And if we put this into a map view using Ocean, which is the e-referral system that a lot of family physicians actually use, you can see in a map distribution, where specific surgeons are, and it's helpful for patients and optometrists to know, because some patients may choose not to travel to Guelph. Let's say they live closer to Kitchener, and vice versa. So it helps both patients and referring care providers to direct the referrals according to geographic location preferences as well. If we go into the e-referral system, it's mostly a drop-down menu, and we try to streamline the process as much as possible to limit this only for elective cataract surgery at this point, and also allow the referring optometrist to put in some very specific data that's pertinent to triaging the referral. So some of the things that we found quite useful was an entry point to allow patients to indicate, do they want shortest wait time? Do they want a surgeon closest to home, or do they want a specific surgeon? And I'll talk a little bit more about that in a later slide. Also important would be information like visual acuity, the staging of the cataracts. And we also find it's helpful to know whether the patient had previous laser refractive correction, or if they want a more advanced technology, non-standard type of IOLs. So these have allowed us to get information in a more specific and organized way. We also allow offices from the optometry side to fax in referrals through a PDF system, because not everybody's EMR system can communicate with Ocean. So we know that things like Accuro or Oscar right now can communicate with Ocean, but for all the other EMR systems, they don't communicate directly with Ocean. So some offices may choose to print the PDF and then fax it to the central intake system. And what we found was initially there was a lot of resistance in terms of taking on to do this from the optometrist side, because it is adding on extra workload. But a lot of the barriers had to do with just improving communication and trying to walk them through the process. And over time, we found that there's been better and better adoption. And you can see slowly over time, there's still kind of 50-50 distribution in terms of referrals that are sent into the central intake system using the online platform versus faxing the PDF. But over time, we have found that there's a little bit more adoption on the e-referral side. That may also have to do with a lot more offices are transitioning more into EMR system rather than staying with paper and faxes. If you look at the volume distribution from inauguration in April 2021 to last summer, unfortunately, we don't have data beyond that because I was trying to get as much updates in the data with the eHealth Center of Excellence, but they do have a lot on their plate. But if we look at from 2021 all the way leading up to last summer, you can see the total referrals received, which is the top dotted light green line there. It continuously increases in terms of volume. There's that big dip there, which indicated the period of province-wide optometrist strike. That really reduced the number of referrals that we get through the system. But overall, you can see there's gradual trend in increased adoption over time across the different regions. If we look at the monthly average number of referrals being received, a lot of it is still within the Kitchener-Waterloo region, just based on the population size, and less so in Guelph and Cambridge. Now, what we wanted to highlight was patient preference. So we have a system that allows patients to go to a centralized system and be triaged to potentially the surgeon with the shortest wait. This way, they don't have to look up who has the shortest wait, and they don't have to necessarily wait 2+ years when there's a surgeon that can get the surgery done way sooner than that. But at the same time, we also want to preserve patient choice. It's very important that within the system, we allow patients to specify if they want a specific surgeon to do the surgery. We want that autonomy to stay in the system. For instance, we may have patients that had one eye done by a specific surgeon many years ago, and they may still want the same surgeon to do the second eye, which is very often the case. So we want to allow that to still be in place, and patients can still have that choice. And we also want to allow patients to choose specific, let's say, a region. So for the reasons I mentioned earlier, we may have a patient in one township that doesn't want to or is unable to travel to a nearby township. So they may want to stay in a specific region and choose from that pool of surgeons locally and close to home. And again, we see that dip because of the optometrist strike provincially in 2021. Now, if we look at monthly average breakdown of patient preference in general, and I would say even to this day, if we look at just the numbers, we didn't have time to put it into a pie graph, but over time, what we've seen is about 40% patients would want to choose shortest wait time, and then about 40% patients would want to choose a specific surgeon. And after that, about 20% of them would want to be closer to home, or they just don't have any preference. So this distribution tends to stay the same over the past year from the monthly data that we look at. So now we're leading up to actually just past our 2-year anniversary. Since April 2021, we have through the system processed over 8,500 referrals. The 90th percentile wait time for cataract surgery, which is the time frame where 90% of patients are treated. 1 month after we go live in 2021 was 354 days, and as of last month, it was 311 days. There is a reduction, it's not a lot, but we do see that number gradually growing and increasing. And because of the transparency that we provide to our patients, we do get a lot of positive feedbacks that you can see, on the right-hand side, some quotes we get from our patients locally. They do appreciate and are actually happier that they can see how long specific surgeons' wait time can be and how long the wait time can be in a particular region. So I think overall patients are happy about this. We still have a lot of data collection and data mining to carry out. But it is something that's very exciting, and we're just proud that locally we can use technology, knowing that we're in the Waterloo region to optimize healthcare. What we've learned over the past couple of years is a lot to do with how data is entered. And, as the saying goes, garbage in, garbage out. If you have very poor data entry, you're not going to get very reliable data to carry out what you need to do. So with the wait 1 and wait 2 system, what we've learned is with wait 1, because the referral is coming from the central intake system to the surgeon's offices, and then the surgeon's offices send the appointment date back to central intake system, it can very easily and automatically update the wait 1 data in the database automatically by Ocean because they have that data all at hand. Now, for wait 2 is a little bit different because once the surgeon sees the patient, that office will have to put the patient on the hospital wait list to get surgery. And a lot of this depends on, at least locally, how on time the surgeon's offices are in inputting that data into the waitlist system. And if, let's say, a patient's name or chart sits on the desk of a surgeon's office and it doesn't get inputted into the waitlist system until later, it can artificially and erroneously kind of change the wait time. So what we've learned is it's actually, it may not be the best idea or solution, but what we've learned is this is one solution that we've come up with is to use the average number of cataract cases done by a surgeon in the last 3 months and kind of use that as a ballpark to estimate how long the wait will be based on the number of patients that are being put by a specific surgeon onto the hospital waitlist system, which is what Novari involves here locally. So it allows us to kind of prospectively calculate and estimate the wait time for patients once the patient's being booked for surgery. So this is still something that we're trying to explore and fine tune. So far over the past year, this has worked out quite well. The data does get updated monthly on our website to improve accuracy and reliability. There were times when data was not entered properly or timely that we found there can be a lag between, on the website, it may say a specific surgeon has the shortest wait, but on the surgeon's office side, it may easily be the surgeon with the longest wait. So the timely data entry is very, very important for the reliability of this system. And Ontario Health has been very supportive of this initiative, and to the point where they're saying that the ministry would like to explore implementing this in other regions. So this is a map of Ontario Health West region, which includes us. and other communities such as London, Windsor, Chatham, Kent. And we're looking at really how this can be implemented. You can see all the arrows directing, the flow of ophthalmologists, where the central intake hubs, hospital hubs can be. And we're actually asked to talk to other regions and see how this can be implemented in other regions. So this is very exciting, and we're just happy to be part of this initiative, and we're still learning along the way. So thanks everyone for your attention. And this is our website. Feel free to check it out, and you'll see our waitlist data as well. And I'd take on any questions. Thanks very much.
Wow, Toby, that was fantastic. Congratulations to you, to Carissa, to really your whole group. You're able to come together and do this. I have a lot of questions, and I definitely want to see what other people have to say. If you could maybe provide us a little bit more context for, I'm thinking the lens of trying to roll this out to other places. Who's paying for it? Like, how much time is this taking from the various people? I know you and Carissa and your group clearly have are willing to spend some time on this. And I'm frankly, I'm just going to be in Canada. I'm worried that other groups may not have leaders who are willing to do it. Like, it just seems like it is a lot of work. I think you did. So that's one area, if you could comment. Another one is just better understanding what you're doing with Second Eye. And this has come up even some private chats to me, and this is going to come up with Sean's presentation as well. How are you building the Second Eye into the calculation, and whether different surgeons do it differently. And then I think you've already addressed this. I mean, of course, the concern would be, I said, let's say that one surgeon is known for a high anterior vitrectomy rate, and that could be interpreted one of two ways by referring physicians. Or optometrists, family physicians, whoever's doing it. But it looks like you guys have a fair amount of spread, where some people just said, I don't care, I want to go to the one of the shortest wait time. Some said location, and others said surgeon. And I'm assuming too that would depend on how acute their cataract is. I'm assuming if someone has a really bad cataract, it's all about the time. Whereas if it's, not really a cataract, then they're willing to wait, for whoever they want. So can you maybe comment on those three areas? And of course, we have Carissa here, and then we'll maybe get Rob to chime in.
Yeah, sure. So the first question about the time commitment and funding. So right now we're actually going to meetings with different regions and with our hospital leadership, and it actually sounds like the province is very, very supportive of this idea. They actually have plans to fund initiation and launching of this system at different regions, different hospitals. And that's what that map was about that I showed earlier. You would see different central intake hubs that they already named and identified. And those are the centers that the Ministry of Health is interested in providing funding. If they can find a lead, be it a center or a group of surgeons or one single surgeon, to kind of bring this forward. Funding wise, to launch, the province actually has money to launch this. It's actually part of our Premier's initiative to reduce waitlist. So we just locally dived in first, but there is money to do this province-wide. Now, as per ongoing funding, that's what I was actually asking Carissa about this last night. It's kind of a blur right now. There was at some point, I would say a year in, where we actually had to ask the hospitals to put in money to continue supporting the technical side of things and to salary the people that's maintaining this. But going forward, we're actually wondering, if the province is actually willing and may already have been funding partly, if not most of it. I think the good news overall is the province is very supportive. So the money would come from the province. Sorry, I forgot your second question, Matt.
Here, I could answer it, Toby. The third question was on one eye versus two eyes, how you handle the second eye. And Matt, we have also an initiative to do bilaterals locally. So I think that may change. We actually haven't discussed with our surgeon group how people are booking it, but I think wait 2 is the biggest challenge of centralized intake, because wait 2 tends to be the longer wait. And it's even beyond what Toby was saying about getting surgeons to input data. That's one of the issues. But the second one is if you have a long wait 2 and a large volume of patients moving around, I could, for example, have 100 patients referred to me, which could increase my wait by, a certain percentage, and that wouldn't be reflected in the data until the patient had surgery. So with large volumes of patients, I think you cannot wait for wait 2. I think you have to do it prospectively, and this is how we've decided to do it, but there may be some better way. But one of the advantages of prospective wait 2 is it doesn't have that second eye skewing. So the way it works is, say I have 300 patients on my wait list, and I do 100 cases a month, my wait is 3 months. That's how we decided. It's very simple math. And every month we look at what are the rough averages of numbers of cases and just pure cataracts. We're talking P3, P4 cataracts. And I think that helps us have up-to-date wait 2s that are not easily influenced. But that's currently how we've tried to do it.
Yeah, well, thank you for sharing that. Just for the audience, because this is, I said, come up in private conversations. Bilateral does really simplify the wait time too as well. But of course, if you had a 6-month wait list, and then if you did the second eye 1 month after the first eye, and you treated the second eye like the first eye, well, you're only having a 1 month wait list for half of your patients. So it means it makes your wait list look like it's 3 months.
But in ours, it doesn't, because
Yeah.
essentially it's like +1. It becomes +1 patient. It actually ends up being accurate because you're still in the average number of cases. So I think that is one of the advantages of doing it. The main disadvantage is it involves someone pulling that data from the hospital. And we did want the hospital to be objective data. It's not reported by the surgeon's offices. It's data that the hospital gets based on patients inputted into the wait times and number of volumes done, per month by each surgeon. But it does require somebody to do it. So there is no question that this system has administrative work, although very little of it is done by myself and Toby. It does require buy-in from the group, and we have had a bit of an issue with that. We've had all the surgeons are in the system, and it is technically mandatory that patients get referred through the system, but we don't enforce it. And we have had a couple surgeons who have not really used it as much, where they are accepting patients outside of the system. And that's a problem. Like, I think the way central intake works is if everybody uses it and all patients have access. So there's lots of growing pains with a system like this. But overall, I would say it's been positive. And there's 2 features that we haven't discussed that are really a real positive. One is if someone retires, goes on a leave of absence, decides that they can no longer take referrals for some time period, it's really easy to just contact centralized intake and say, hold my referrals for this time period. Or if you have a new recruit to the community, we've had a few, they can build their wait list within a month or 2. They can come in working full efficiencies. So for those kind of variations in practice patterns, the system is it's very strong. And then the last one is if there are surgeons in the community, and there are less now, but there used to be more in our community, who don't do certain kinds of cases. So say surgeons don't want to do multifocals, don't want to do torics. You can have that built into the system, but it's not advertised. So what I mean is if the optometrist identifies, and it is a mandatory field, I think this patient may want a toric or a multifocal, they will not be referred to a surgeon who has said they won't do that. So it does kind of allow patients to get referred to the appropriate providers.
Yeah, that's excellent. It seems like a lot of thought has gone into some of these nuances. So thank you for that. Rob, go ahead, and then Ike.
I just really want to congratulate you guys to start off with, Toby and Krista, and your colleagues at the eHealth Center of Excellence. Just terrific work. I know how hard it is to get provincial level funding to do something like this, and know how hard it would be to implement this in this way. And hats off to you. Congratulations. So I was just thinking, reflecting about some of the remarks I said this morning. This really exemplifies in many respects the patient-centeredness part of what we're intending to do. You know, you are actually asking about patients' preferences and actually asking and respecting their preferences in terms of their choice of surgeon and their choice of home. And that absolutely is a key component to patient-centeredness and patient experience. The transparency that you provide, the tools that you give to patients directly around their data, their wait times, those types of things. And I would imagine even if you didn't improve the wait times at all, you would improve the experience of patients with cataract surgery because you are doing those things. So just hats off to you. Just two questions from me. One is we had a lot of discussions yesterday about the use of potentially patient-reported outcome measures as a way to prioritize and determine appropriateness. And I wondered whether, now that you have patients interacting with their information, whether you've actually considered extending this with the Mental Health Center of or the eHealth Center of Excellence to do patient-reported outcome reporting right into the system, so that you could potentially use things like CatQuest in your waitlist strategy. So that was the first question. The second one was, I also noticed on your diagram, on your intake form, that you were collecting socioeconomic factors, and whether you'd actually had an opportunity to look at equity in wait lists to see whether there are real differences in wait times by different socioeconomic strata as you're moving through this. So those are the two questions for me.
Yeah, thank you, Rob. Both are great ideas. Definitely, I'm taking notes. So definitely these are the areas we can tap into and look into. Thank you.
Can I just say that, you know, we actually did use CatQuest. Toby and I modified CatQuest, like not scientifically, just practically, because CatQuest has, I think the main issue for a community like ours is, how do you interpret it without, like, we didn't want to have to use like an Excel spreadsheet to interpret the responses, but we used it during COVID to try and prioritize patients based on need when there was resource issues in terms of accessing surgery. And I think our main limitation now is just that it would be more administrative burden to the referring providers and to the surgeons. And with any system like this, I think that's generally the biggest pushback, is that it's just one more thing that you have to do in the office. And I think it was already a lot to get all of our group to do it. So I guess our main reluctance to do that would be burnout in terms of the administrative load. But we have definitely spoken about how can we use quality measures, because we definitely, with Ocean is something used by family doctors, as Toby said, and it has Intuit questionnaires built in. Most family doctor offices who do, you know, like pediatric well baby visits, all those questionnaires are done through Ocean. So there definitely is a capability to do that. And I think, you know, as we get more used to the system, that would make sense. We have not looked at the data, but that's a great idea in terms of socioeconomic status. But that was definitely used in diabetes, which is why we included it in ours. We looked at their central intake form when we created ours.
Great. Go ahead, Ike, and then Kylan, and then we're probably going to move on to Sean.
Yeah, I again want to applaud both of you. I mean, this is just a model for all of us to use and look at. And Rob kind of stole my question a little bit, because I think the opportunity to incorporate, you know, some form of patient intake to use for appropriateness and prioritization, I think would be a wonderful opportunity. I think we really have to make this part of the conversation. I mean, we would not think about looking at, again, not looking at visual acuity as part of the intake for determining appropriateness. And so I think we just have to change that conversation. It has to be, you know, really part of that mandatory assessment. And I think, you know, how to incorporate it, I'd be interested to hear, you know, the initiatives that you're looking at. The other area I think would be interesting, which I think we just, you know, sadly have not included enough, is, you know, our primary eye care colleagues and our family physicians. And I'm just curious, maybe from Toby and Carissa, how that went, and how you know, how the engagement and the buy-in from optometry and family practice colleagues went into this initiative, because I think that's got to be such an important part for this to take off and be successful.
I could answer that. I mean, I think the main barrier, again, is the EMR compatibility. One of the advantages of Ocean for physicians is that it will it'll import data in terms of demographics, saving you the need to like duplicate that kind of data entry. So if you use PS Suite or Accuro or Oscar, there are advantages administratively to Ocean, and really no optometrists use those systems. So their EMRs are not compatible, so they are duplicating their work when they use this. And I would say that has been our main limitation to uptake. But generally, I would say people that use it like it because it provides them with data. There's been a frustration in optometry that they don't have access to our wait times. They don't know who has the shortest wait. They don't know kind of the differences. So I do think that has been a real positive. And the other positive that they've told us about is in terms of getting appointments. So if you refer a patient, you don't know when their appointment is. With Ocean, it'll automatically notify the referring provider of every step in the process. So if you send me a patient and my staff opens the referral and accepts it, they'll get an email saying patient was accepted. And then when I give a date, they'll get an email with the date, and so will the patient. So there are kind of advantages in terms of communication that I think they have liked. And really, when we've done more outreach, like Toby and I did some kind of town hall meetings with optometry around this, especially in the first year, we got some good buy-in, but it's not perfect. And I would say that to get optometry buy-in, you need ophthalmologist buy-in. And in all of our communities, it's not equal. So we have 3 cities. In Kitchener and Waterloo are really good. In Guelph are really good. In Cambridge, we need to work on it. So I think you really have to kind of continuously engage with both the ophthalmologist and the optometrist to make a system like this successful. Family doctors are not really part of this system. We sort of decided that referrals for it, because it was cataract based, had to come through optometrists. So we have kind of engaged with family medicine in terms of setting up centralized referral, but not in terms of like getting online and using the system.
Yeah, just adding to what Chris has said, I think ease of use is key. Nobody wants extra admin work. So we're actually in the process of streamlining that PDF or the online platform even further. We allow optometrists to actually attach their own referral letter to the referral. So they may not necessarily need to fill out everything on that long form. They can just fill out the essentials and then just attach a file. So yeah, we're still in the process of improving the referral, the ease of referral.
Great. Kylan?
Yeah, I mean, I'll echo everyone. It's such an amazing local community thing. You guys should be really proud of that. It should be hopefully translatable. My couple questions would just come in that vein of translatability for other communities. First of all, Toby Griesa, are you guys part of a general kind of call group? Because that's one of the challenges we face as people sometimes look for different wait times in different areas. And then we get into, I can tell you as a chief of surgery, issues with those folks being followed up later with complications. And secondarily, I know Matt invited me to ask the uncomfortable questions. So is there issues relating to some referrals that patients would go and have surgery outside of a hospital setting? And I'd be fascinated if you've correlated this to your total capture rate of cataracts done in the region. And yes, that's the question I know everybody didn't want to ask, but I was gonna. So thanks.
Yeah, thank you, Kylan. So yeah, I'll answer the second question first. So the private route, where volume actually goes through specific surgeons that are being done in non-hospital facilities, totally outside of the OHIP system, that doesn't go through our central intake. We made that decision very early on that should not be included in the central intake system. So we do have patients that ask about it. Like for instance, just last week I had a patient asking me, oh, I want to pay $3,000 to get my surgery done like next week. So that specific case, it wouldn't go through the central intake system. But we do locally have partnerships between hospitals and non-hospital surgical centers that are taking on OHIP volume. So that is still being captured by the central intake system. Now, in terms of trying to encourage adoption within the call group, we are in a call group regionally, like all 3 of the townships or cities that I mentioned, we are in the same call group. And like Chris mentioned, it's hard to kind of make this mandatory. At this point, it's not really mandatory, and we're trying to encourage our colleagues to take this on. But there can be different reasons to surgeons being hesitant to take this on, time commitment and extra admin work, and some may actually worry about, oh, where's that data going to go, and then are there organizations or someone out there that's going to abuse the data to their own benefit and make the problem worse for specific surgeons. So I think so to give you an example, like on the orthopedic side, the QBP funding allocation is actually tied to this. So surgeons on the orthopedic side, they actually have to use the system. Otherwise, it affects their QBP funding allocation. And we haven't seen this in ophthalmology yet, but seeing how, that's just me thinking out loud. So seeing how the ministry is encouraging different regions, at least in Ontario West, to adopt this, it may be something that we may see down the road in the near future, that our QBP cataract surgery volume allocation may be tied to adoption of this kind of technology. So time will tell. But locally, I think, yeah, we're just trying our best to encourage everyone to come on board.
Thanks so much, Toby. That was the last quick thing I was just going to say for everybody. With it being in orthopedics for so long, that was one of the things we faced for orthopedics was they wanted, at least the admin wanted to readjust surgeon allocation based on wait times. And if you want a hot topic, that's definitely one.
Yeah, and I think David, addressed that a little bit too in some of their data tracking. So thank you, excellent. And I really like, I do think at some point this will be imposed in some places, but the fact that Toby and Carissa have been willing to be part of the process at a grassroots level, I think only helps everybody. So thank you.